Good morning. So we are wrapping our DNB sessions, and we have started with the revision of our chapters. Like this month we are dealing mostly with hernias. So today we will have a case discussion on a complex ventral hernia. We have mentioned that it's a case of having a patient having loss of domain. So these are the cases which are kept in the exam as a long case. And Dr. Malavika Rao, who is a third-year junior resident at Apollo Gleneagles Hospital, will present the case. And with us is Dr. Sarfraz Beg, a very avid AWR surgeon and ex-assistant professor of surgery at Calcutta Medical College, now at Wellview Clinic. Will moderate this session, and I'll also be there. Malavika, you can share your screen and start presenting. You stop at the end of history, and then you have some questions, and then pass on to examination, and then go for discussion. Unmute. Unmute karo, Malavika. Yeah.
Milind has the slides. He's supposed to be displaying them.
Okay.
And your glasses. Slides.
Slides visible?
My patient. Hello?
Yes, we can hear you.
Okay.
We can see your slides.
Mrs. Shamli Das is a 77-year-old lady. She was a resident of Howrah and a homeless of Howrah. She came with acute complaints of swelling in the right side of the upper abdomen for the past 10 years and blackish discoloration of the skin over the swelling for the past 4 years. Next. Oops. Mrs. Das was apparently all right 10 years ago when she underwent emergency emergency surgery for peptic ulcer perforation. Post-operatively, she developed a minor wound infection, but she was discharged uneventful. She was managed with conservative treatment, and she was discharged in post-operative day 7. 1 month after the surgery, she noticed a small swelling to the scar while coughing, which has gradually grown to attain the current size. It would initially appear on coughing and standing and reduce on lying down. But with increase in size for the past 6 years, but with increase in size for the past 5 years, it does not reduce on lying down. There is also associated dull aching pain over the swelling for the past 5 years, which is aggravated on straining and decreases on lying down. There is no associated. I think there is some problem with the PPT. It's not. I sent another one.
Sorry. And it's okay. We carry on. Okay. You know the case, right, Malavika?
Yes,
so you can carry on.
She also has a history of chronic cough and obstructive sleep apnea for the past 10 years. There is no history of fever, vomiting, non-passage of stool or flatus, ulcers discharged from the skin over the swelling, no history of chronic constipation, dysuria, or respiratory distress. Past history of surgery for peptic ulcer perforation in the by upper abdominal paramedian incision 10 years ago, and his history of open cholecystectomy by right subcostal incision 50 years ago. For the peptic ulcer perforation is an emergency surgery, which was emergency surgery for peptic ulcer perforation. She had peritonitis and was admitted for 7 days, including 2 days in the ICU. She also had a minor wound infection, which was managed conservatively. She's a known case of chronic obstructive pulmonary disease, non-insulin dependent diabetes mellitus, which is uncontrolled, obstructive sleep apnea, and hypertension, which is on she's taking medications for. Personal history: bowel, bladder, and appetite are normal. Sleep is occasionally disturbed due to OSA and coughing. Otherwise, she has no known drug allergies or addictions. General examination. She's conscious, oriented, and cooperative.
Wait. We can have some discussion on the history presentation.
Yes.
So, from the history, Malvika,
Yes.
what is your inference about the lump?
From the history, it is apparent that it is a hernia. But there are the size of the hernia is, was not visible because she was wearing very loose clothing. Other than that,
That's all right. We're just talking about the history now. So from the history, you can tell us that it is possibly a hernia, an incisional hernia, right?
Yes. Incisional.
Okay. And what can you tell us about the etiology of this incisional hernia from the history?
So from the history, she has a history of peptic ulcer perforation. So she definitely developed. She says she developed peritonitis, and she underwent emergency surgery. And after that, she had a minor wound infection with ICU stay. All of these are risk factors for incisional hernia development. And she's old and has other aggravating factors like COPD, OSA, and uncontrolled diabetes.
Right. Nakunda?
You said there is some black discoloration in the skin. In the
Yes,
chief
sir.
complaint, you said that.
Yes,
So
sir.
what is that? Is it a skin having intertrigo or skin having some other changes? What is that? Because in history, I did not find that point.
Sorry, it was missing from that. But it was when I examined her, it was actually skin necrosis over the apex of the swelling.
No. If there is skin necrosis, you have to find out when it started and how is this necrosis. Is it discharging anything? Because they are all important. Patient having an overlying skin necrosis because of a large hernia is a surgical emergency. Okay. What she said when this black discoloration started.
She's been having it constantly for the past 4 years. Over 4 years, it had become thin and had slowly ulcerated and developed into then it become blackish discoloration. That's all she had said. But she's been complaining of that for the past 4 years.
Okay, very unusual. Patient having a skin necrosis living around for 4 years is very unusual because once you have skin necrosis over a large hernia, it is an emergency, and anytime patient might have viscera being extruded. Okay. Okay. Otherwise, you have gone through other points. Yes, you have to keep in mind the important points in this patient why it has led to hernia, because she has all the factors, and some are patient-related factors, some are general factors, and again, is surgical technique also important for development of such hernias? She underwent an emergency operation.
Yes.
What in surgical technique is important?
Layer by layer closure is associated with higher risk of hernia than en bloc closure. You don't have to, if you have a very tight closure of the abdomen, it is associated with muscle necrosis and causes hernia. In emergency conditions,
what about suture material?
Suture material, if you use absorbable suture material, if you use delayed absorbable suture material, is now preferred for delayed absorbable to non-absorbable is preferred.
So it was you said paramedian incision. Most of the people use closed paramedian by using absorbable suture, but if you use polyglactin, the strength is gone by about 15 to 30 days. How long a suture should maintain its strength for a proper wound healing, so that healing is proper, this hernia is not coming up soon? What should be the ideal strength of suture and time that should be maintained?
6 to 8 months.
6 months. Why 6 months?
Because
when the wound starts healing, what is the chronology? You remove the stitches after 7 days, na? So is the wound all right by at the end of 7 days? You remove sutures of the skin at the end of 7 or 8 days. Is the wound healing over by 7 or 8 days? What happens?
So there is a stage of inflammation when there is
how do you, Malvika, how do you define tensile strength of a wound? How do you define tensile strength of a wound?
I don't know.
You see, tensile strength is a common physics definition. Tensile strength means the amount of force that wound can take. That means you remove the suture. If you now pull apart this suture line, it will open up. So this is important in wound healing. As the wound healing progresses, there is laying of collagen. Initially, it is immature collagen, and with course of time, this immature collagen type 1 is converted to type 3 mature collagen. And at the end of 6 months, the wound gains about 80% of the tensile strength. At the end of 1.5 years, it gains a near normal tensile strength. So a 6 months time is critical, so that you should use a suture which will hold the wound margin adequately for about 6 months, so that the wound gains good amount of tensile strength. So that is the idea of using a suture. Either use a non-observable suture, and now we have a suture material PDS which maintains tensile for about 6 months. So that is also important. The type of suture material that is used is also important. And the postmortem happenings. This patient has got a minor wound infection. Okay, she has chronic cough with COPD. So these are all the factors which are inducive for developing hernia. Okay, Dr. Safaraj, you can pass on to examination.
Yeah, we can. Just adding one more point, that the suture length should be at least 4 times the wound length. And that is something very, very important nowadays, considered to be very important. Small bites at smaller intervals, and suture length at least 4 times the wound length.
Malvia, what is the recommendation now? What should be the distance from the margin, and what should the consecutive distance of each bite you take while you're closing abdominal incision?
So 1 centimeter from the margin and 1 centimeter gaps should be
1
more than
centimeter was earlier. Now it is said 5 millimeter.
Okay.
It was earlier description was 1 centimeter. Now people are saying that it should be 5 millimeter from the margin, and the consecutive is 5 millimeter. So that's how you calculate the suture length. If you are going exactly with these norms, you will be using 4 times the suture of the wound length. Okay.
I examined my patient in a private room with her consent and with adequate exposure. She was conscious, oriented, and cooperative. BMI was 35.9. She's an obese lady. She has adequate hydration and is malnourished. Gait and
35.9 malnourished. Oh.
As in obesity. Obesity is a form of malnourished.
Oh, okay. Okay.
Yeah. This is now the new concept.
Okay. Then you should have mentioned the obese part only.
Okay.
You have mentioned BMI this, and then you can. Okay, carry on.
Gait and activities of choice. She's afebrile. Pulse of 90 beats per minute, regular, normal volume and condition of arterial wall not variable. BP 160 by 80 millimeters of mercury in the right radial artery. Respiratory rate of 16 per minute. No pallor icterus, cyanosis, clubbing, edema, or lymphadenopathy. Generalized. Abdominal examination on inspection. The abdomen was mildly distended with a large 20 centimeter by 15 centimeter swelling over the right hypochondrium, right lumbar region, epigastrium, and the umbilical region. The umbilicus is deviated to the left and inverted. The skin over the swelling is thinned out and shiny with patches of necrosis. 2 scars are running across the swelling. One is the right costal scar, which appears healthy, and the right paramedian scar is atrophic, hypopigmented, and stretched out. There is an expansile cough impulse present. The swelling is smooth in contour and has diffuse margins and edges. The skin over the rest of the abdomen is normal. The rest of the hernial sites are normal, and there is abdominal thoracic respiration. There are no visible peristalsis or dilated veins or scars over the rest of the abdomen. Palpation. Temperature over the swelling is normal, and it is a non-tender swelling. There is a single large 20 centimeter by 15 centimeter swelling in the right hypochondrial, right lumbar, epigastric, and umbilical regions. It's soft in consistency, non-reducible, and non-compressible. There is an audible gurgling sound when the swelling is pressed. The margins and edges are well defined. Facial defect is approximately 10 by 10 centimeters, but it was difficult to assess. The rest of the abdomen is soft, non-tender, mildly distended, and has no palpable lumps or organomegaly. On percussion, there's a tympanitic note heard over the swelling as well as the rest of the abdomen. There's no ascites. And auscultation, normal peristaltic sounds are heard over the swelling as well as the rest of the abdomen. Systemic examination is essentially normal. My provisional diagnosis. Should I proceed with the diagnosis?
You need to
So,
summarize in one slide.
Yeah, give me a summary first. Yes.
Okay. From the history, sir.
Yeah. Summary would mean
History
history,
and
brief
examination,
history,
both.
brief exam.
Okay. My patient is a 77-year-old lady who is a homemaker and resident of Howrah. She presented with the complaints of swelling in the right upper abdomen for the past 10 years and blackish discoloration of the skin over the swelling for the past 4 years. She underwent surgery 10 years ago for peptic ulcer perforation, after following which she had a minor wound infection and was discharged on post of day 7. 1 month later, she noticed a swelling, which was small initially and reducible, and but has gradually increased in size over the past 10 years, and it has become irreducible. Irreducible. There is blackish discoloration of the skin over the swelling, and there was periods of ulceration as well as discharge, but now it is completely there's complete skin cover, according to her. There's no history of fever, vomiting, or non-passage of stool or flatus. She's a known case of COPD, OSA, and diabetes, uncontrolled diabetes mellitus, and hypertension. She is, but she doesn't have any history of constipation, dysuria, or.
Summary, see, Malvika, summary is not extensive
Exactly.
elaboration of everything. Summary is brief points which are important for diagnosis. Okay, you should summarize that way. So the one slide should be there with one paragraph on summary and one paragraph on examination. Don't start saying everything again.
Okay.
Yeah, Malavika,
Yes,
I
sir.
would like you to think about summary as you start saying about the patient. Let's say this is a X-aged patient, non-diabetic or obese, diabetic. That's what you know, right? So now you can start saying Mrs. So-and-so, age so-and-so, diabetic, obese, COPD with sleep apnea, presented with the chief complaints of a swelling for the last 10 years and a pigmentation over the skin for 4 years. On history, detailed history suggests that she had a surgery 10 years back for a peptic perforation, which had a post-operative wound infection, following which she noticed this lump, which has increased in size over the last few years to attain the present proportion. Now, that is your history of the chronology of the disease. And then you say that's the history of the lump. Then you say history of the complication and history of the etiology. So this is how you keep it in your head. So the etiology, the patient has history of chronic cough, which is the etiology, one of the contributing factors. And she does not give any history of pain abdomen, abdominal distension and vomiting, suggestive of obstruction. But that is important for us, isn't it?
Yes.
Now, this will finish your history. And then you can say general examination was unremarkable, because it was. And clinical local abdominal examination revealed. Now you can tell me how you want to say. So just to tell you, you have to have a plan in your head when you say a summary. Okay, so you talk with the patient particulars, chief complaint in the one line. Then you talk about the history of the lump, briefly, the chronology, and then history of complication, the history of etiology. That is what we want to hear. And then now tell me about the abdominal examination.
Abdominal examination, the abdomen was mildly distended. The swelling itself is a soft, doughy swelling, which is 20 by 15 centimeters.
So I'll stop you here. See, when you say soft, doughy swelling, you are taking us elsewhere. The feeling of the lump is either soft, firm, hard, elastic. If you're talking about hernia, you're probably talking about elastic feel, right? And if you say it's hard, you're talking about malignancy. If you're saying it is soft, you're talking about some vascular lymphatic lump, right? And if you're talking about firm, you're talking about benign tumor like a lipoma, fibroma. So choose your word carefully. I would suggest that if you say this is elastic, because you said that it was a gurgle when you pressed it.
Yes,
so it's probably elastic feel.
Another thing regarding the examination, Malvika, when you have a patient of hernia, it may be partially reducible or sometimes may be reducible together. So your examination should start with a statement saying, I examine the patient first in standing position. Okay, for any hernia, including incisional hernia,
Yes, sir.
you assess the swelling on standing position. And on standing position, we look at the abdomen, such a large swelling in the upper abdomen, definitely abdomen is asymmetric. Abdomen cannot be symmetric with such a 20 centimeter swelling. So on standing position, you first examine the patient and comment about what you say is not the examination only of the swelling. This is a patient where you're going to examine the abdomen as a whole. Okay, so the first you say, I'm standing position, I'm examining the patient. Abdomen appear asymmetric.
Okay.
With a swelling in this region and describe the swelling there. Comment about, you have commented the umbilicus.
Okay.
Okay. Comment about the skin. Comment about the visual peristalsis because you said there is a gargling feeling about the swelling. And then comment other hernial sites.
Okay.
Then you make the patient lie down. And then you look at whether the hernia is getting reducible. If it is irreducible hernia, standing and lying down doesn't make a difference. If it is irreducible hernia, the swelling will remain same. And you can describe on lying down position.
Okay.
And then in the abdomen, you should also try to look for any other lump because this patient may have some other underlying disease.
Yes, sir.
Okay, if you can appreciate in a large swelling like this, you cannot appreciate the liver enlargement also. Okay,
Yes.
so you keep in mind that you are going to examine the swelling plus the abdomen as a whole. Okay, now summarize. Summarize the examination part.
The exam, yes, there is a large swelling of size 20 centimeters by 15 centimeters. I examined my patient. Sir, I don't have to say that.
Both in
Sorry.
standing and supine position.
Say that.
I'm sorry, I couldn't hear you, sir.
I examined the patient both in supine and standing position.
I examined my patient both in supine and standing position. There's a large swelling, which is 20 centimeters by 15 centimeters in the right upper quadrant, involving the right hypochondrium, right lumbar, epigastrium, and umbilical regions. It was plastic in consistency. It was a non-tender swelling. It is soft, elastic in consistency with smooth surface, well-defined margins and edges. The facial defect, it was not very well appreciated. It was 10 centimeters by 10 centimeters.
In a irreducible hernia, try to understand. In a irreducible hernia, don't try to comment the gap on clinical examination. You cannot feel. If you cannot reduce the hernia, you cannot find the margin of the gap. So you say, I cannot assess the gap because the hernia is irreducible.
Okay. I could not assess the gap. The content appears to be there's a gurgling sound on pressing, which suggests that the bowel is as a content. It suggests bowel as a content. There is a tympanitic note on percussion and normal peristaltic sounds heard over the swell. The rest of the abdomen.
Malvika,
Yes.
Makunda told you, you can start saying that you examined in standing and supine position. And then it's like inspection, palpation, percussion, auscultation, right?
Okay.
In a summary.
Yes.
So on inspection, abdomen is asymmetrical. There's a large 20 by 15 centimeter lump in the right upper quadrant, spanning from the epigastric, umbilical to lumbar region. The skin over the swelling appears unhealthy. Umbilicus looks normal. Other hernial sites appear okay. There's no cup in other hernial sites, like the groin and the umbilicus. And then you say on palpation, I could feel the lump. The lump appears to be, now if there is bowel, then obviously it's elastic in feel, but it is irregular, right? Irregular. You cannot, you can see that the lump is disappearing at the right costal margin. That is what you think it should be. Posteriorly, you have to tell us whether it is going up to the anterior line, mid-axial line, or, where is it going to? Is it crossing the midline? Is it going up to the umbilicus? So that is how I'll understand. When you say I have to imagine, but if you do not, I cannot imagine, then I do not understand what kind of lump you're talking about. After that, you can say it is non-tender, temperature is not elevated, and on pressing it, it is not irreducible. It is partially reducible or not reducible. And there's a gurgling sound. And then on percussion, you can talk about percussion and oscillation. But you go in a methodical order, then it is easier for everyone to understand. You
Yes,
understand?
Yes,
Yeah.
sir.
Makonda, you agree?
I agree. But again, in the provisional diagnosis, clinically you are saying hernia with loss of domain. You see, loss of domain is a different entity. Although I've given you a clinical scenario, say with the loss of domain, but I think clinically in a obese patient with 20 cm lump, we should not state to a comment clinically she has loss of domain, because loss of domain has to be assessed on some objective criteria. Okay, you can say is a complex ventral hernia, you can say.
Okay.
Because such a large hernia with possibility of gap of about 10 centimeter. So you can say it's a complex ventral hernia, but I think the term loss of domain should not be used at the end of just clinical examination.
Okay, sir.
That you assess with some investigation. What do you feel, Dr. Safra?
Yes, absolutely. Loss of domain, in fact, doesn't have a definition so far in hernia surgery. There was a consensus meeting just 2 years back, and they couldn't come to a consensus, but they came with a definition which was entirely clinical. And you cannot say from whatever you have presented so far whether this patient has a loss of domain.
Yeah.
So the definition now stands as a large hernia where there is a clinical suspicion that if one tries to reduce the content into the abdomen, it may lead to postoperative abdominal compartment syndrome, or to bring the defect, close the defect, it would need some form of component separation technique. So imagine even the definition is very vague. So when you write loss of domain, you are inviting trouble. I totally agree with Makonda that you say complex ventral hernia.
Okay.
Nobody is going to object to that. But when you say loss of domain, you're inviting a little bit of a trouble. Let the examiner ask you what a loss of domain.
Yeah, plus this patient has got a overlying skin necrosis. All this makes it as a complex. There are some. What do you mean by complex ventral hernia? How do you define a complex ventral hernia?
Sir, if there are any skin trophic changes, if there is any obstruction or strangulation, if there is incarceration.
That is emergency. Apart from this, in elective setting also, you may have a situation we call that a complex ventral hernia. Even obstruction, strangulation is also a different entity where patient is emergency intervention. There are some criteria to say this patient has got a complex. That depends. Number one is gap.
Okay.
Which gap makes a incisional hernia complex?
If there is cheesecake, sorry, the Swiss cheese defect, then
Swiss cheese
multiple
one, multiple defects, then single defect, of which size you will say is a complex hernia? More than 10 centimeter. Okay, some people say 8 centimeter. Okay, what else? You will find patients who had got a associated enterocutaneous fistula. Okay, you can find a patient who has got a chronic infective sinus. If you find a patient who has got a recurrent hernia, a recurrent incisional hernia is always taken as a complex hernia because already patient has got one attempt at hernia repair. And then patient has got loss of domain, which will be objectively assessed afterwards. So they are the definition for a complex. In this patient, you see, with such a large swelling for 20 years with overlaying skin changes, you can say it's a complex ventral hernia. Loss of domain will come for discussion. Fine. Okay.
So I'll just add one more thing here, Makonda.
Yeah.
For her, you nowadays, when we say see a hernia, we talk about patient factors, hernia factors, wound factors. Any of these factors can make it complex. So if you have a sinus, as Makonda said, or a gut fistula, that makes it complex. If the hernia factors has a large width, like more than 8 centimeters, that makes it complex. If there is Swiss cheese, as you mentioned, that makes it complex. There is loss of domain, that makes it complex. And there are patient factors which can make it complex.
Yeah.
For example, if the patient has got uncontrolled diabetes, sleep apnea, morbid obesity, this makes it complex, right? So any of these factors can make it complex. In your patient, both patient factors and hernia factors make the hernia complex, right?
Yes, sir.
Okay.
Hello.
Yeah. Okay. So that is a diagnosis. How will you proceed with this patient?
So I would like to do a couple of investigations to support my diagnosis.
To support your diagnosis means you have a doubt about hernia. You need an investigation to support the diagnosis of hernia. What
to get
investigation?
more information about the hernia.
Yes. Don't say to support the diagnosis. Diagnosis, hernia diagnosis is clinical. This patient having all the classic features of hernia, don't need an investigation to confirm hernia. It's a hernia, but you need some investigation, definitely. Because such a large hernia, you need a lot of information from this patient. Yes. What do you like to do?
Ultrasonography whole abdomen, which will tell me the contents of the hernia, and if possible, maybe sometimes the gap of the defect can also be assessed, but that is only history. Okay. Then I will also get a CCT of the whole abdomen.
No. Ultrasound, you must mention one more line. Ultrasound exclude other intra-abdominal disease. Is a lady, she might have some pelvic pathology. She already has gallbladder surgery done. Okay, so you might need to see her CBD. Okay, yes. So ultrasound is for just the hernia assessment and also for any other underlying abdominal disease. Okay, next is
CT scan of the abdomen, preferably with contrast. So CCT, it is done to assess the size of the volume of the hernia, hernial content, volume of the intra-abdominal content, and the size of the defect. And in addition, you can also measure, find this the rectus abdominis dimensions, because that is important for the posterior compartment. And the loss of domain is assessed based on the.
No, before loss of domain, you're trying to say the abdominal muscle. It is not only rectus abdominis muscle. A good quality CT scan can give you some more information about the abdominal wall. That is important. This is an obese patient, the large hernia. So what else you look at the abdominal wall?
The musculature, the gap of the
gap, and the bulk of the muscle. You see, these because of the large hernia, these muscles are stressed up. These muscles can be thinned out. Okay, you can see the rectus muscle is a paramedian hernia, so rectus muscle might have been pushed laterally. Okay, so this CT scan also gives an idea about the abdominal wall musculature. That is important in managing these patients. Okay. Yeah. And what is the CT criteria to say the patient has got loss of domain?
Yes, sir. There are two criteria. One is Tanaka's criteria and one is Sabag's criteria. Tanaka criteria is the ratio is the hernial sac volume divided by the intraperitoneal sac volume. And Tanaka criteria is a ratio, and more than 0.2 is considered as loss of domain.
You can say as percentage. You can say as percentage. When you make the hernial segment of peritoneal volume, more than 25%, some people say 30%, it is taken as loss of domain. Why this calculation and the loss of domain assessment is important preoperatively?
So that we can plan our technique of repair. Then we also have to prepare the patient preoperatively and check the pulmonary function and assess.
What are you preparing for, Palvika? Whenever you say there is a loss of domain, what is your fear?
That once we reduce, the patient is going to develop abdominal compartment syndrome as well as respiratory discomfort. So we have to assess how far how much the musculature will be compliant in order to get closure of the abdomen.
Yeah. So we were talking about loss of domain. How would you optimize this patient? You said you will do tests. First of all, I'd like to say that when you say tests, what are the tests being done in an exam, irrespective of whether it's a hernia case or any other case? So you should say, I would like to do the tests to assess to assess the general condition of the patient. Here, to confirm my diagnosis is not at all needed because it is a clinical diagnosis, but to evaluate the locoregional anatomy. In hernia, it would be to evaluate the locoregional
Okay.
anatomy. So, so the tests, obviously, when you assess general condition of the patient, would be pulmonary test like a chest X-ray, cardiac test like an echocardiography in ECG, you know,
Yes.
kidney test like a creatinine. But when it comes to locoregional anatomy, an ultrasound and a CT scan, and whenever you say contrast CT scan, now it is known that it is not mandatory in a hernia case to do any contrast. So don't volunteer that information. Just say CT scan of the abdomen.
Okay, sir.
Most people do not believe that we need any contrast for evaluating a hernia patient.
Okay, sir.
That's another. And then when you said that what are you going to evaluate? Obviously, you'll evaluate the defect width, the length, the content, the Tanaka index or the Savag index, Savag percentage. You would look at the bowel content. You would exclude other pathologies. You would look at the abdominal wall musculature, the lateral muscle and the rectus, and the overlying skin. So if you see that the skin is very thinned out, that means that that skin cannot be kept. And if you see on the right side, see there's a right subcostal incision. And then there is a right paramedian incision, which means that the right subcostal incision has divided all the nerves between the T6 to T10 at least, depending on the extent of incision. That could be more. Now, once that has happened, the rectus muscle of that side will be atrophic. So you could actually volunteer this information to the examiner that I will do a CT scan of the abdomen and I would look at these things. I expect to find a huge defect. I expect to find the NACA index more than 25% based on clinical assumption. And I expect right rectal muscle to be atrophic. Now, this would be a very good answer because that suggests that you have understood what you're looking for. Okay. All right.
Okay.
Please carry on. Please carry on.
So clinically, this patient has got large hernia, and CT scan wise, you say patient has got loss of domain. So what's your plan for this patient?
So my plan is to first preoperatively optimize the condition of the patient, general condition of the patient. First, complete evaluation and optimize, and then counsel the patient for surgery and take her up for.
With loss of domain, can you have any other measures to be taken pre-op in respect to the hernial part, apart from general conditions?
To measure
Because the loss of domain, the fear is if you do surgery, there is chance of interabdominal compartment syndrome. How can you prevent that?
So by I will ask the patient to do exercise and do weight loss, diet control, and control her sugar levels by referring to a diabetologist.
That is general. I'm talking of the hernia part. Hernia part is important. You see, this patient has loss of domain means this content is out of abdomen for a long time. And now you're trying to put it back because syndrome, compartment syndrome. How are you going to have some more space in the abdomen? One is she can take rest, keep on gradual reduction of the hernia. Then, as you say, chest physiotherapy.
Yes, sir.
Then any other measure which can increase the abdominal volume?
So this is I don't know if it's done now, but earlier there was serial dilatation in serial pneumoperitoneum, which is done 40 days before surgery, starting from 40 days before surgery, and you do 3 to 6 sittings.
Apart from pneumoperitoneum, any other technique for expanding the abdominal wall? One is repeated pneumoperitoneum.
Yes, sir.
Anything else?
Intraoperatively, there are
not intra. Intra is different.
I don't know, sir.
Use of some tissue expanders. And third is now people are coming with the concept of botulinum injection.
Botulinum.
Okay. So if you give botulinum injection in the muscles, it causes stretching of the muscle. So this stretching will increase the intra-abdominal peritoneal volume. Okay. So whatever you do in this way is different, but you should know the different ways because in large complex hernia, this is a very challenging situation. Not all patient can be managed with component separation.
Yes.
Okay. So some patient will need pre-op optimization with any of the measures.
Okay. Okay.
Okay. Dr. Sarfraz, how do you go?
Yeah, so that is fine. I think you must mention it's called progressive pneumoperitoneum, PPP. And botulinum toxin injection is given in the lateral muscles, that you should know, these two things. And these two are, yes, they were there in the past. Progressive pneumoperitoneal has come back again, and people employ it for patients with loss of domain, essentially to increase the intra-abdominal volume and to also decrease abdominal wall compliance, which means even if the volume is not increased, there is a stretchability which allows the patient not to have intra-abdominal hypertension despite higher volume.
Okay.
So these are the two concepts coming up. You should at least remember to say these.
Okay, sir.
I think Vakunda, we can talk to operative.
Now then patient is optimized. Sugar is controlled and you can't help a lot of obstructive sleep apnea, but you should have some precautions. Patient having obstructive sleep apnea may behave badly in the posterior period.
Yes, sir.
Okay, so that is one part you keep in mind, and then otherwise optimized. What surgery you plan for this patient?
I would plan for
Gap of 10 centimeter.
Yes, sir. I would plan for a posterior compartment separation as transverse abdominal release (TAR) with a synthetic mesh,
So you need some form of component separation. That is an open technique.
Yes.
Okay.
Yes, sir.
So what is exactly component separation? You say TAR. What do you do exactly?
In posterior component separation, we reach the pre-transversalis or pre-peritoneal space, and then we dissect laterally and separate the
No. You first raise the skin flap. You get the hernial sac. What is next? Now I got the large hernial sac in front of me, and the hernial sac is going up to the margin of the defect. What do you do with the hernial sac? Open or don't open?
We don't open, sir.
Don't open. How do you reach then? If you don't open the hernial sac, how can you reach the layers of the abdominal wall and do a component separation?
So we do the subcutaneous dissection peripherally and
no. You cannot reach the transverse abdominis. That you are talking of anterior component separation. That is different. To tackle the hernia, you have to open the sac. Because in the sac, there might be some addition of the contents. There might be some momentum. So you have to open the sac, reduce the content, lyse the adhesions. Then how do you reach the layer to do a posterior component separation? Where you have to go?
The posterior to the rectus muscle. So, posterior to the pre-transversalis fascia. Pre-transversalis plane.
As you come to the margin of the defect, at the margin of the defect, you find all the layers are blended. So what do you have to make now? You make an incision. Make an incision to separate the posterior rectus sheath from the anterior rectus sheath. And now you dissect. How far laterally you dissect the posterior rectus sheath?
To the mid-axillary line.
Mid-axillary? Where is that?
Line.
No. As you go, have you seen an operation? No. Okay. So then you have to describe theoretically. You dissect the posterior rectus sheath up to the linea semilunaris. That is the junction of the lateral border rectus abdominis. Okay. That is the point you go. So that you dissect up and down. Now you said you are ready for posterior component separation. Where you made the incision the transverse abdominis? What is the guide? You have decided the linea semilunaris. Where you should divide the transverse and where you should start in the upper level or start in the lower level. You see, at this level, the nerve fibers supplying the rectus pierces the transversus and reach the rectus sheath. Okay. So it should be remaining 1 centimeter medial to the linea semilunaris and start incising the transverse abdominis muscle bit by bit. Start from the upper level. Why? Why do you start the split at the upper level? You'll notice during gallbladder surgery at the upper level the transverse abdominis is more muscular. Okay, at the mid level it is aponeurotic,
Okay.
and the lower third all comes anterior. Okay, so if you want to do a component separation, you start inside the muscle higher up, where you find the muscle bulk. Once you made the incision, what do you do next? You made an incision in the transverse abdominis. So there is a now split in the transverse abdominis muscle in the aponeurotic part. What do you do next?
So we
How
create
will you gain length? So you dissect laterally. As you dissect laterally, where do you reach?
the
If you are going deep to the transversals, you are reaching in the
preoperative
plane of first transversal plane, and dissect laterally till the flanks. You can see the quadratus lumborum. That creates the mobilization, and you can gain up to 8 to 10 centimeter length on each side. Okay, so that is how you do posterior component separation. And then now you'll oppose the gap.
Yes,
You will
sir.
put a mesh or don't put a mesh.
I will put a mesh, sir. I will put
From
a
where
mesh.
to here?
So from 4 centimeters beyond, it has to be 4 centimeters beyond the. It's a 10
That
to 20,
means
10 by 20 centimeter mesh, which is spaced across the posterior rectus sheath.
posterior rectus.
Sheath over the sublate space retrorectus.
No, you have not seen the operation, so that's why. So once you make this posterior component separation, now you have a lateral margin of transversus, which is having a large gap between the medial leaf and the lateral transversus. So you have to put a large mesh, which is about 30 centimeter. So this mesh will be bridging between the lateral cart margin transversal one side to the other side. Okay, so this mesh should be covering the gap between the cart margin transversal abdominis, and you should go above and below. So that is the intricacy of large mesh in case of component separation. Okay, would you drain the area?
Yes, sir. I'll put a
Why?
subcutaneous drain because there is a large
Subcutaneous. Only
yes,
subcutaneous drain will place. Again,
intra-abdominal.
there is controversy. Some lab surgeons say they will not put a drain, but most of the people will put a drain because you have done a large area of dissection.
Yes,
There
sir.
is chance of seroma formation there. Okay, Dr. Safraj, you can discuss something about
Yeah.
laparoscopic part.
Okay, so first of all, Malvika, you must see this surgery. Go on the YouTube channel, type transverse abdominis release, and at least see the operation once so that you have an idea about how to do it. We have a channel ourselves, so you can watch in our channel also. But at least see it once so that you understand what is happening.
Yeah.
And you said 20 by 10 centimeter mesh. No, that's not acceptable. When you are doing such a complex ventral hernia, the entire purpose of building such a huge retromuscular or sublay space is because you want to put a huge mesh with a good overlap. And that means that most of the time you land up putting in a 30 centimeter by 30 centimeters macroporous polypropylene mesh. So that is number one. And of course, your understanding of this procedure is limited because of the of your experience, but then you need to see it at least once to understand how to speak in the exam. Let's say that this patient did not have such a huge hernia. She had a hernia which was 4 centimeter by 4 centimeter gap, and a sac was big, but the gap was small, not as big as the one which you presented. And the Tanaka index was 5%. And I said that we can do this endolaparoscopically. What would you recommend? What procedure would you recommend for this patient?
I would recommend a laparoscopic IPAM plus, sir, which is intraperitoneal onlay mesh as with primary closure of the defect, anatomical closure of the defect.
So now this defect is very close to the costal margin.
Sorry, sir, your voice is getting
The
cut.
defect is close to the costal margin.
Okay, sir.
Then
I don't know, sir. Hello?
Yeah.
I don't know, sir.
So if it is close to the costal margin, it is difficult
Am
to
I
close the
going
defect.
to place the puncture the heart, or am I? Hello.
Yes, Dr. Beck. Repeat.
Oh, so did you get my question?
Yeah,
I
if it is close to the costal margin, yes.
must imagine.
Yes. So
I
how are
don't
you
know.
going to manage now?
I don't know the answer.
Okay, so A, that is the side effect of IPOM plus. In the IPOM, since the you have to fix the mesh to the peritoneum, you can do it for midline hernias. When you talk about atypically sited hernias like this one, then in that case you have a problem. Which is why the one thing you can do is you can suture the mesh superficially or leave it untagged, unsutured above the costal margin, so that
You are muted, Dr. Beck. Dr. Beck, you are not audible.
the other option is to do. Can you hear? Hello, can you hear me now?
No, the last part was not audible.
Okay.
You can please repeat.
Okay, I will say it again. Yes. So when you're tackling a hernia in the midline, an IPOM plus will be very suitable.
Yeah.
But when you try to tackle any hernia which is close to bones, like a subcostal hernia, subxiphoid hernia, right iliac fossa hernia, suprapubic hernia, then since you cannot tack the mesh or fix the mesh to the bone, then the problem of IPOM starts. That is a limitation. So one way in subcostal is that you can leave the tag the mesh at the costal margin and leave the part of the mesh above the costal margin without any sutures attached, so that it is sandwiched between the liver and the peritoneum. Or you can take superficial sutures, being careful not to take deeper bites.
Okay.
That is one way. And the other way is to go for extraperitoneal repair. Extraperitoneal repair would be an endoscopic reef stopa, which could be done either in a ETEP axis or a TARM axis, transabdominal retromuscular axis, or you could go directly into the retromuscular space. So I don't think you need details of this, but I'm just telling you that this would be the right answer.
Okay.
If anybody asked you a question that what would be your endolaparoscopic approach, then you can say this much, that this is how I can change my IPOM plus fixation, and the other one is to go for an extraperitoneal repair. Okay?
Okay, sir.
Yeah. Okay.
Malvika, you should be aware about the EHS classification for ventral hernias.
Yes, there is classification for ventral hernias. It is on the recurrent state and then the surgical site event occurrence, surgical site occurrence rate. Grade 1, which has a low risk for SSO and recurrence.
No, Malavika, you're talking about VHWG classification. That is different. Makonda is asking you about EHS classification of hernia, which means
clinical description.
Yeah, you have to talk about the site and the defect width, based on which, for incisional hernia, it can be L1, L2, L3, L4, N1 to M5, and width could be W1 to W3. So that is EHS classification of incisional hernia. But you should know it.
Okay.
Again, the classification is different for primary ventral hernias, like epigastric or umbilical or spigelian and lumbar. The size defect is different in these two EHS classification. So EHS classification for primary ventral hernias and EHS classification for incisional hernias. Where the width for primary ventral hernias is W1 is less than 2 centimeter, W2 is 2 to 4 centimeter, and W3 is more than 4 centimeter for primary ventral hernias. For incisional hernias, the W1 is less than 4 centimeter or equal to 4 centimeter, then W2 is 4 to 10 centimeter and more than 10 centimeter. So that indicates the width of the hernia. And then depending on the location, it can be M1 to M5 or it can be L1 to L3. And then more lateral hernias. Okay, so this is, you should be knowing the EHS classification also for ventral hernias. Any other question? We have discussed this part. This is the important thing you require. And then you should be knowing the anatomy of abdominal wall. How is the rectus sheath formed? What the nerves are lying in the rectus sheath. Okay, and the disposition of the flat abdominal muscles, their origin, their insertion, they're all important for abdominal wall reconstruction. Now the concept is changing. It's not only the repair of hernial defect. It's a complex of abdominal wall reconstruction.
Yes. No, I think it's fine for her. This is enough.
Good.
Okay. Thank you very much. Makunda, I'll take leave.
Yeah.
Thank you.
Yeah.
Thank you, Malavika. Thank you.
Yeah. There are two questions. Yes. One is explain the index for loss of domain. Index is is a index calculated on CT scan, where CT scan can give you a measurement of the hernial sac volume. So you measure the hernial sac area and find the hernial sac volume. Apart from the hernial sac volume, you calculate the peritoneal volume and make a ratio of hernial sac volume divided by peritoneal volume into 100. So if it is more than 25%, it is said to be that patient has got loss of domain. That is one way of calculating. IPOM is intraperitoneal only mesh placement, and IPOM plus is in intraperitoneal only mesh placement. You don't close the defect. If the defect is less than 2 centimeter, you can just place the mesh as a only mesh placement. And if you are closing the defect with a suture and then place the mesh intraperitoneally, it's called IPOM plus. Okay, so there is no other question. We can conclude.